Mi sentite?
Sì, benissimo.
Sì, Aldo, sì.
Possiamo cominciare?
Assolutamente sì. Eccoci qui, io inviterei anche gli altri colleghi, la dottoressa Rossi, Andrea Monteriù, e non so se c'è Alessandro pure collegato. ad attivare le telecamere, così. Lorena, ti vediamo a metà. Ok, adesso ci sei. Bene, vedo Aldo frizzato, Aldo Siciliano, che adesso magari ci sbloccherà. Ok.
Bruno,
credo che sia il caso di ovviamente parlare in inglese, perché potrebbero esserci ospiti, anche studenti, diciamo, stranieri. So I think that now we can start with this first edition of the school, the summer school, on active aging, active and healthy aging, well-being and smart living, addressing challenges and enabling technology, but much more than this. On the behalf of the organizer of the school, so myself, Bruno Endo from the University of Catania, Alessandro Leone from the National Research Council Lecce, Andrea Monteriù from the University Politecnica delle Marche, and Lorena Rossi from the National Institutes of Health and Science and on Aging, Ancona. It is a very pleasure to start with this first edition of the school and to welcome all of you. You are many more we were expecting at the very beginning, so we are very happy for this. And as you will see, I suppose that all of you already looked to the program. The plethora of speakers is very, very wide. And this is good because the idea is to focus this subject, the subject of active aging and well-being under different perspectives. So we'll talk about the impact of the technology on the society, so the famous user-centered design approach, of course, technology, so we're going to talk about sensors and many other things like robotics and signal processing, and of course also the architectural aspects in this field. But this will be just the first year of a 3-year schedule, because the idea is to hold this school also for the next 2 years, addressing the same topics but with different, of course, subjects. And so it's a pleasure for me now to leave the floor to Dr. Pietro Siciliano, who is a real expert in the field and is also the president of the Italian Association of Active Aging and Wellbeing, but he will be much better than me able to present and introduce itself. So please, Pietro.
Okay, thank you very much, Bruno, for your kind introductions. And good afternoon to everybody, and welcome to this this school, which is an action internal to the National Technological Cluster on Smart Living Technology, and together with the Italian Association on Ambient and Assisted Living. Unfortunately, due to the COVID pandemic, we decided this year to organize this school online. We hope the next one will be in presence directly and hopefully in a very nice place also in Italy, So the idea is inside the framework of the action plan of the National Technological Cluster, which is a national cluster funded by the Ministry for Research, in the sense that they should activate it like a national driver of this kind of activity, of this kind of items to drive different actors in different regions in Italy in order to form ecosystems on active and healthy aging. So, of course, in our 3 years plan of the activity, we include all the part related of the training part, and so some different schools dedicated to the young researchers and PhD students, like something else, covering the field of students, but also operators in emerging sectors related to active and healthy aging. So in principle, the clusters activity is spread into two big pillars. One is related to smart living, generally speaking, and the other one is specific for the technology for active and healthy aging and the assistance at home for elderly people, but also in general for fragile peoples, which is very actual in these periods and after what we have learned after the experience of COVID-19 pandemic. So it's becoming much, much more important and relevant. How is important in the same way that other field of activity could merge inside these topics, like in interdisciplinary activity, where we have engineering, physics, material science, and the clinical part, social and psychological part that work together. They have to work all together in such a way to reach a better objective, covering also different market segments, which cover the domotics, the telemedicine, teleassistance, robotics, wearable devices, sensors, and so on. So we did our best to include this argument inside the topics to be dealt with inside the schools during this the different step, a different day in which you could assist to the to participate to the lectures. And of course, we not cover whatever we want, but we did our best in order to include different multidisciplinary aspect in such a way we can give you an overview of the complexity of the matters. Before leave you to the lectures, I would like to thank very much the director of these schools, or the 4 directors of these schools, and Lorena Rossi, Bruno, Alessandro Leone, and Andrea Monteliu for the organization of the school in all the aspects. And finally, I would like to wish you a profuse school in such way we could enjoy very much, and of course you will have you will increase your knowledge in a matter in this emerging matter which is related to the technology for elderly peoples, which is an emergent need of the world society in the world. Thank you very much, and enjoy the school.
Thanks a lot, Pietro, for the nice introduction and the very warm welcome to the audience. I don't want to say students because maybe we have more than this. So thanks a lot. Yes, the Italian community is very active, no, in the field of assistive technology or assistive and health and active aging. So for sure, I think that the contribution of Italian speakers, but worldwide international speakers to this school would be very, very interesting and very informative for the audience. I will leave the floor now to Lorena, which will introduce this first day of work, and I will see you soon during the next days. And of course, I wish all of you a very, very fruitful exploitation of this school. Thanks a lot.
Okay, thanks, Bruno. First of all, I would like to give you some practical information. At the end of the two sections of the day, you will find in the chat the links to fill in some questionnaires. One questionnaire is about what you have learned during the day, and should be completed including your name and email, just to evaluate at the end these questionnaires. And other two questionnaires will be related to the performance of the lectures and will be anonymous, but please, I hope that you will fill in even this questionnaire, because they are really important for us to evaluate at the end the final performance of the school. I will post this link at the end of the second lecture, and you will have 1 hour to complete them online. And at the end, we will evaluate the answers to the questionnaires, and this will be the basis for the final evaluation of the school for the ones that need the final assessment. And now I would like to introduce you the first teachers of the day, that is Dr. Cosimo Tuena. Is a psychologist from the Istituto AUXOLOGICO in Milan. Is a researcher in the area of psychological impact of aging, and his experience in the use of technology in the care of elderly, and in particular in the use of virtual reality. His lecture will have the scope to introduce to you which is our main target, to understand which are the characteristics and the needs of the elderly people that represent the primary user of the solution that we all work to define. So I'm happy to leave the floor to Dr. Cosimo Tuena.
Well, good afternoon to everyone. It's a pleasure to be here, and thank you to the organizing committee for this very interesting school. It's great to have a lot of different disciplines involved in this school, and as you may notice during the whole school, it's crucial to have different perspectives on the topic, and particularly on the topic of aging. So I will share my screen. Let's see. Okay, I hope that everyone can see it. So as Lorena said, I'm a psychologist and researcher at the Istituto Auxologico Italiano, but I'm also a PhD student in Catholic University, as many of you, I think. And so my aim is to provide some information about the geriatric patient. And I would like to, it's very hard maybe in 1 hour and 1 hour and a half to give detailed information about the whole spectrum of conditions that affect the older people. I would like to just provide some inputs that may be useful for you to start thinking about technological solutions in this particular population. So I don't know if I think that we are like 50 or maybe more students, but I would like to hear from you what pops up in your mind when you think of an older person. If you have some keywords that are specific to that condition. If someone wants to break the ice, otherwise I will go with mine keywords. So maybe I think as a clinician, and as a researcher, I think the first thing is complexity. So not that the other conditions such as infancy or childhood or middle age are easy, but as you know, as you will notice during this lecture, being old is complex because there are different conditions that characterize this stage of life. Another one is frail. So even if someone can age well, of course, is no longer like a 30 or 40 years old person. So it is frail, but it's frail in different aspects, which could be the physical aspects, the cognitive or psychological domain, could be frail also in terms of socioeconomic aspects. So I think that a good word for aging could be frailty. I think also to my grandma, and I think that there is a tight bond between in aging with relationships, in particular long-term relationships. Another aspect is autonomy. So even if you age well, you may observe a decline in physical functioning or even in cognitive functioning, which is normal, perfectly normal. But if you have a disease or more diseases, chronic diseases, you will have an effect on your autonomy, which has a great impact then on your quality of life. And of course, it is crucial to overcome the lack of autonomy. The caregiver could be the parents, the partner, could be also the healthcare professionals, the nurses, for instance. And these figures are crucial for the patient. Even if he has no critical condition, the whole environment is critical for the aging population. Of course, doctors and hospitals visits. As someone ages, the number of visits and the consultation to specialists increases, and we will see why in a while. Medication, and of course, if I have to visit many specialists, because I have different medical conditions or impairment, they will prescribe a lot of medications, and they will also prescribe maybe different kind of non-pharmacological intervention to prevent some conditions. And also grandchildren, which are a big resource for the older person, and hobbies and free time as well. But on the other side, many of the people that are older may live alone, so they feel isolated. And lastly, the long-term relationships, as I said. So with these keywords that I thought about when I was writing this lecture, I think that provide a nice overview of what is the condition, the situation of an older person. So, and during the lesson, I will cover some topics that may help you to answer some more broad question about aging. So the first one is, what is aging? I will provide some definitions of aging and how the population is aging, especially in the European part of the world. Then I will cover the main condition associated with aging, such as disability, multimorbidity, and other conditions. Then I would like also to talk about the care models. So how do we care from the healthcare professional to the institutions and even maybe policymakers and politics are caring for the older people with chronic diseases. Then as a psychologist, I will do a focus on psychology and neuropsychology of aging, and particularly dementias and neurodegenerative diseases. It will be hard to give detailed information about this part, but as you may find useful to have an overview of the aspect of aging, and particularly psychology and neuropsychology, of one of the most debilitating condition of aging, which is dementia and neurodegenerative diseases like Alzheimer's disease, Parkinson's disease, and which are degenerative. So they are highly debilitating. They have huge costs on the patient, on the healthcare system. And then I will cover some aspects of the management of such conditions and give you some hints about the technology. As Lorena said, I'm specialized in virtual reality for cognitive rehabilitation and assessment of mild cognitive impairment, which you will know, which I will explain you later in the presentation what is. And so I will also show you some patients interacting with a system that we are developing at Istituto AUXOLOGICO, just to provide you with some actual applications. So what is aging? Aging is a condition that has biological and psychological changes that are associated with the chronological age. So there are two main aspects, which is the biological aspect, which is the deterioration of the system. And then there are the psychological changes that are associated with all the thoughts, emotions, and beliefs, and also the psychosocial system that surrounds the patient or an elderly person, that are associated with being old. So we have a primary aging, which are the changes which are completely normal. I mean, it's inevitable to age, and these factors are cannot be modified. I mean, we can do prevention, and now prevention is a key aspects of intervention, even if you're not ill, so someone does not have a condition, it's good to do physical activity, do cognitive and engaging in mental activities, and increase the social relations to basically to have an active life. And then there's secondary aging, which is the pathological changes that are due to environmental factors, lifestyles, and diseases. And these are like, for instance, Alzheimer's dementia, unfortunately, are not modifiable. You can try to slow down, for instance, cognitive decline in this in Alzheimer's dementia, but it's very hard to treat it. So when does one age? Typically, the cutoff that is provided by the World Health Organization is 65 years old, which is a bit arbitrary because there are, it's hard to find a cutoff because aging is also very subjective. So you find people that are 65 are really fit and are engaged in physical activity, and then you find other people that are less active and have a disease and so on. But there are other cutoffs that you may find specifically in scientific papers because of scientific reason. It's good to add, for instance, a cutoff of the sample of a study. So what is the current situation in Europe? As you see in this graph, this was an Eurostat analysis in 2019, and you see that by the end of 2040, so 2050, there is an increase of almost 50 million of people aged 65 and over. So the colors light orange, orange and red, the span here is increased. Sorry, is increased compared to here. So the fact is that people are living longer compared to maybe 500 years ago. There is an increase in life expectancy, and these, as you will see, have a huge impact on this condition. So the situation in Italy and in other European countries is that, so as you may know, Italy is a country that has a lot of older people living because younger couples do not do children, and for other aspects, and also because of increasing life expectancy. And as you see here, the light orange and red aspects colors cover the 35 or 36% of the total population in Italy, whereas, for instance, in the northern countries, on the right part of the graph, in Iceland, for instance, it's very low. In Ireland, it's 24.7%. And however, we are not alone. Like if we look at the other countries in the world, for instance, Japan is known for having a lot of centenarians, so people that have more than 100 years old. And in fact, there are many studies studying why people that live in Japan, and in particular regions of Japan, live that longer. Another aspects of aging in Europe, and basically elsewhere is that women live longer. And so there is a gap in life expectancy between males and females, because males tend to die before. So as you see here, there's a lot of women 85 and older compared to males. However, as I said, there is the gap between these two populations is narrowing. So and it's comparable in Italy compared to the other European countries. But again, the life expectancy in some of the Northern European countries is way higher than Italy, and also the European countries, the 28 European countries. And so the first aspect of life and of life in the later age is morbidity, which is the absence of health. And disability is the presence of disability is the most frequent use metric to estimate morbidity. As you see here, Italy, there is it's very spread, the self-perceived health in Italy. So in the blue line represent the 16 years old population and over, which has a perceived self-perceived health of 80, almost 80. But as age increases, you see that the self-perceived health decreases. And again, there is a huge gap, for instance, compared to Switzerland or Norway or Iceland. And this unfortunately represent the current status of Italian situation. And what are the typical conditions that affect the elderly? So the first one is cancer. So we have a different chronic condition such as cancer, arthritis, hypertension, and other cardiovascular diseases, but also metabolic aspects such as diabetes type 2, cerebrovascular diseases, which are strokes, and other pathologies that affect the brain vessels of the brain. And we have also geriatric syndromes. So geriatric syndromes are not diseases, but are a cluster of symptoms and signs reported, which are due to different, that could be due to different etiologies. For instance, MCI, which is mild cognitive impairment, is a geriatric syndrome that is characterized by a mild decline in cognition compared to normal stages. And this decline could be due to different etiologies. So it could be due to underlying Alzheimer's disease pathology, could be due to Lewy body pathology, which is another neurodegenerative disease. It could be due to Parkinson disease, or could be due also to lack of to diabetes. Also, people with diabetes may have a mild cognitive impairment. Maybe people also with depression could have mild cognitive impairment, and if you treat depression, then you may find an improvement in cognition, because the underlying condition is treated well, and so you have an impact on your cognitive functioning. Then we have incontinence, frailty, and frailty, I will explain later on what is frailty. There is a more broad and common sense definition of frailty, which is someone that is basically weak, but in the medical area and research area, there are more specific definitions of frailty. We have depression. Depression is also another aspect of aging. So someone could have a primary depression, which is due to a psychiatric condition, but depression may arise also as a secondary condition. So someone could have a chronic condition, a debilitating chronic condition, cancer, or the loss of a partner, and then you will have you will find in the patient depression. So it's not unusual to find depression in comorbidity with another condition. And we have anemia and sarcopenia, which is loss of muscles. And so again, there is a complex picture of conditions that can affect people in the older age. And the issue with morbidity is that it does not have a metric. So someone could, of course, diagnose a given pathology or a given condition or disease, and you may find 2 or more diseases and conditions in one patient. But another aspects or another metric that we can use to assess disability and morbidity is by assessing the impact that a given condition or a multiple condition has on the autonomy of the patient. And so by assessing activities of daily living. So ADL is highly used questionnaires that is often filled out by caregivers or the clinicians, sometimes by the patients itself, if he's aware does not have severe and moderate cognitive impairment. And it assesses hygiene, so the ability to assistance for toileting, dressing, so getting dressed, toileting, locomotion, so be able to have a walk to buy things at the grocery, continence, and preparing meals. And these 6 areas are basically the ground of our daily activities and are often used as a measure of quality of life and to target, to create and design intervention for older people. And as you see here in this graph, there is a huge imbalance on the between women and men. I think I personally I think that this is more due to a cultural aspect. I often administer the ADL questionnaire to patients, and sometimes I see that maybe they are not autonomous, for instance, in doing laundry or preparing meals, because they answer me, oh, my wife does it. I never touched a meal or never did the laundry. So there are also cultural aspects that are part of this picture. And of course, there was a patient that I met, and I answered, oh, are you able to do laundry? And he said, since my wife has died a few months ago, now I have to face this thing, and now I have to learn something that I never did before. And of course, it's harder because he had my cognitive impairment, so he's starting to decline in terms of autonomy and cognition. And then on the upper part of the graph, there's instrumental activities of daily living, which are the use of telephone, the management of medications, and also administer the financials of the family. And these are target aspects that you may find interesting to support with some technologies that you may learn to design during this school. And here you see the situation in Europe concerning three aspects in addition to cognition that are crucial during the aging, which is seeing, but the most impacted are hearing and walking. So these aspects then have an impact on your autonomy, because if you do not hear well, there is a lack of interaction with the others. If you cannot walk, there is a reduction on your autonomy. And of course, especially hearing and walking and physical activity in a more broad way, these are crucial risk factors for dementia. So if you do not treat hearing with the proper aids in the later or mid stages of life, you will have an increased chance to develop dementia. This is because there is a deterioration in some parts of the brain that are related to Alzheimer's. If you do not do physical activity and do not engage in physical exercise, then there is an increased chance to develop some sort of dementia in the later stages. So another aspect of morbidity is the classification of medical conditions. So, and according to acute, subacute, and chronic divisions, you have different needs of a patient. So let's take the case of a stroke, a cerebral stroke. A patient with stroke can have an acute, here is called also hyperacute stroke, and in these stages there are specific symptoms that a patient with stroke can have, such as difficult speech difficulties, or in the worst cases aphasia, which is the inability to express, to talk. Someone can have also hemiparesis to one side of the body, so difficulty in moving an arm, a foot, or both of them. And these can be treated if properly with the medication in the stroke unit, and if treated well, they recovers. And so in the subacute phases, there are different aspects that characterize a patient with a stroke. The issue is that symptoms can be chronic. So after 6 months, if the patient does not recover, may develop what is called post-stroke dementia. So the ictus has an impact not only in the first weeks or months of the patient, but can impact the life and the autonomy of patients even 6 months later, and even years, because if a patient with stroke develops dementia, then this means that cognition and autonomy will slightly and progressively decline over months and years. And so if a disease is chronic, it is by definition permanent, so you cannot go back to a previous condition. Is caused by non-reversible pathological alterations, and requires a long period of care. So there is, in most of the cases, no cure. For Alzheimer's disease, which is a chronic condition, there is no cure. There's no currently a cure for stop the deterioration of brain cells and atrophy in the brain. And then there are diseases that are acute, and symptoms here do not appear suddenly, and are severe in symptoms. For instance, a stroke is very debilitating compared to at the decline and progression of a patient with dementia. You cannot tell the different day by day in a patient with dementia. You can see it by months. 6 months is a reasonable time to assess patients with dementia. With a stroke, you notice immediately the symptoms. And if treated well, can recover, can have a natural recovery. Here in the Swedish National Study on Aging, on a relatively large sample of almost 3,000 patients, they find the prevalence of chronic diseases in older people in Sweden. And these are hypertensions that account almost for 73% of the prevalence of older people with such chronic diseases. Then there is dyslipidemia, which is basically high cholesterol, and chronic kidney diseases are the three main conditions that affect patients with during the older age. And another aspect is that when there is an increased chance as we age to develop different conditions, and in the worst case, multimorbidity may occur. Multimorbidity is by definition the co-occurrence of 2 or more chronic conditions in the same patients. And the fact is that in terms of clinical aspects, functional aspects, all the conditions have a priority. So there is no, all conditions have the same weight basically on a patient's life. And in the aging population, there is a high prevalence, as showed by the Marangoni and colleagues study, which ranges from 55 to almost 100%. And the fact is that the multimorbidity is positively associated with mortality, of course, and also with other socio-demographic aspects such as older age. So as we get older, there is an increased risk of having multimorbidity. Females, of course, because they live longer and it's related to having a higher age, and low socioeconomic status. As a consequence, having 2 or more chronic diseases has an impact on quality of life, functional decline, and also aspects related to the economy. So treating many chronic conditions has a cost on patient and on the healthcare system. An interesting study, again by Marangoni, is that chronic condition, not in the majority, but in some cases, may cluster and group. So even if there is almost 50% of unclustered multimorbidity condition, there is a overlap between, for instance, psychiatric and respiratory diseases. There is heart diseases, so here are clustered at different cardiovascular diseases. They tend to gather together, and there is a link between eye diseases and cancer, and cognitive and sensory impairments. And as you see here in this nice but a bit confused graph that I will try to explain you, there is a evolution over time in patients with multimorbidity. So there is the huge cluster of unspecific group of chronic condition that tend to be, as you see, at 6 years, being again clustered, and then at 12 year, again, they are clustered. Some of them will die at 6 year, patients will die with unspecific cluster. But the interesting is here, so in the colored part, so psychiatric and respiratory diseases, they tend to evolve at 6 years in a new cluster that is neuropsychiatric and respiratory diseases. And then at 12 years, the majority of the patients will die. Then there is the heart diseases cluster, which has a high mortality because most of the patients at 6 years, they die. Then there is the eye disease and cancer cluster, which surprisingly remains stable at 6 years, and then at 12 years becomes eye and musculoskeletal diseases. Then there is a cognitive sensory impairment, which basically after 6 years is one of the most deadly cluster. And then there is the respiratory and musculoskeletal diseases, which remain basically stable over time. So the question is, how do we assess multimorbidity? Multimorbidity, is that diagnosed or maybe assessed by adding just the number of chronic condition. There are different diagnostic criteria to diagnose dementia or hypertension and other diseases. And if the chronic diseases are on the same level of impact, so someone could say that the patient has Alzheimer's disease and hypertension. But there are also some scales which the most used is the cumulative illness rating scales, which also was made in the geriatric form, that is administered by the physician, that try to tap and assess different systems of the patient. So the cardiovascular respiratory system, the gastrointestinal system, the genitourinary system, the musculoskeletal system, the neuropsychiatric system, and the general health. For each of these items, then there is a, let's say, a degree of severity. So let's say that the physician assesses the neurologic domain, and according to the patient level and symptoms and signs, the physician may give a point of 1, 2, or 3, or 4. So 4 represent the highest disability, and 1 the lowest. And so you have numeric quantitative estimation of the multimorbidity of the patient. Then we have comorbidity. So comorbidity by definition is slightly different than multimorbidity. Comorbidity is basically the effect of one condition in addition to an index disease. So the index disease is the disease that holds the priority on the clinical and functional output of the patient. It's, let's say, the most severe. So here are some examples. Heart disease and diabetes may often present together with hyperlipidemia and hypertension. So basically here the triangles, the black triangles represent that between the 70 and 80 years old range, there is an increase of prevalence of heart disease, which is the index disease, and alteration of cholesterol indices and hypertension. The same here, but with a different trend. From 70 to 80 years old, there is again a high prevalence compared to the other combination of this condition of diabetes, which remains stable, in addition to hyperlipidemia and hypertension. So a particular condition that affect the elderly is depression. And you may find often depression in addition to other conditions. So patients that have had a cardiac event, so a stroke, may have also depression. They have depression because they cannot have the same quality of life. They cannot do the things that they did before the cardiac event. There is a high prevalence of comorbidity of depression with cancer, with cerebrovascular stroke. There is also a comorbidity between anxiety disorders and depression in the older people, and I will explain in the next sessions why. And also chronic pain. So if I have chronic pain, then my autonomy, my quality of life is reduced, and this may have psychological implication, which may lead to depression. There is again a tool that can be used to assess comorbidity. So in reference to an index disease, to the most critical for the patient disease, the physician had a score according to this the presence of these conditions. So congestive heart failure has a weight of 1, so it's less severe compared to metastatic cancer or HIV, which had the highest impact on the index condition and on the quality of life of the patient. So the main causes of that are basically cardiovascular in Europe, and cancer and diseases of the respiratory system, which basically are the same in other part of the world, such as US countries. We have a prevalence of 24% of heart disease, cancer 23%, and chronic lower respiratory diseases. So these three conditions are the most impactful in terms of death. However, for instance, mental and behavioral disorders or disorders of the central nervous system, like neurodegenerative diseases, they may not lead directly to death, because, for instance, in the later stages, patients with dementia, they die due to systemic reason, not for the disease itself, but such conditions, such as degenerative diseases, has a huge impact on autonomy and quality of life of patients and caregiver. So there is maybe a distinction to do with causes that are directly related to death and conditions that are not directly related to death, but that has a huge impact on patient life. And as a consequence, given the fact that if multiple chronic conditions are present in one patient, there is an increase in seeking medical consultations, especially consultations, and this may lead to a condition that is called polypharmacy, which is defined as the situation in which the patient has 5 or more medication to take. And as you may know, drugs and medication may have a lot of side effects. And so another important aspect is the management of the medication in the patient. And so here the graph just show that there is an increase, a huge consultation in Italy of doctors here, surgical practitioner, and also self-reported prescribed drugs. I spoke in the first part of the presentation about frailty. So frailty, in the common sense, is just might define as the presence of weakness or a person that can easily go through or develop a disease. But there are two main definitions, medical definitions, that are used in clinical practice and research, that are the frailty phenotype by Fried, which is the presence of 3 or more of weakness, slowness, low level of physical activity, exhaustion, so fatigue, and weight loss. And then there is the frailty index by Rockwood, which is based on a comprehensive geriatric assessment, which is created by the number of diseases, physical and cognitive impairments, and also psychosocial factors that can affect an older person. And frailty, as defined as a medical condition, could increase the risk of mortality, hospitalization, and disability. Nevertheless, as you see here in this graph,
Queste sono le informazioni che ho trovato su internet.
For frailty, not all the patients with frailty have comorbidity or have disability. So as the presence of an ability in one or more of the activities of daily living. But there is a modest overlap, almost 21-22% of frailty, disability, and comorbidity. So frailty is another condition in the elderly that should not be overlooked by physicians, by researchers, because it is associated with mortality and disability and hospitalization. So given these such premises, what is happening? So there is an increase of longevity. And given the fact that there is an increase of longevity, as a biological consequence of that, there could be an increase of morbidity, so the presence of disability. And there is now a switch, an important switch in terms of approach to aging. The earliest model was the failure of success model, which basically said that there's little to do to avoid the poorer outcome in later life. However, now there is the active aging paradigm, which is a new paradigm in gerontology, which is the science of geriatrics and old age, that says that it's possible to improve future outcomes in such population. So what is the goal of active aging? Active aging is one of the terms that you may find in the literature. We can say also active aging, successful aging, aging well, and others. The main objective of active aging is postponement of morbidity rather than mortality, which tries to compress morbidity in a shorter period and possibly later in the life. So it decreases the fact that an older person may accumulate chronic diseases and more generally diseases during the lifetime. So this is the main objective of active aging. And there are studies that demonstrate that successful agers compared to older people that live normally have a reduced mortality. So it is important for even if someone does not have a disease to have an active life approach. So it's important not only to focus on disease, which I talked about so far, but it's important to note that even in normal aging, it's important to engage in a positive mindset and successful aging strategies. So engaging in healthy lifestyles, strengthening social support, engage in social participation, which is basically have activities that are related to the social environment, and preparing also the mindset for aging. So this is more related to the psychological aspects. So as one ages, there are different psychological challenges that we face. So during childhood, there are some psychological milestones and difficulties that one has. As we grow, there are other challenges: university, work, career, and also family, change of role. So from being a father or being a mother, and then this is the same for older age. There is a switch. So you go on retirement, you became a grandma or a grandpa, and so there are a lot of psychological challenges during the old age. And then the financial part. And interestingly, in the study from Shu and Chang here, they show that among these 5 types of successful strategies, the less efficient was the financial security. So it's important that someone not only cares about money and financial security, but also to improve general health and psychosocial aspects of aging. And it is possible to fight disability and mortality, for instance, by engaging in physical activity. So there was this huge longitudinal study, the runners study, that showed that engaging in physical activity reduced the average disability reported over almost 20 years. So as you see here, the runners group showed at the end of the follow-up a reduced disability compared to people that did not engage in physical activity. Another aspect, as I already mentioned, is depression. So depression, being depressed, and has a huge impact on life and also on mortality. So there is an increased mortality for people during aging that have depression. And so it's important, and now I start to introduce technology, to have a comprehensive geriatric assessment that can be aided by technology. So CGA, the Comprehensive Geriatric Assessment, is a method that assess different critical aspects of aging, which are polypharmacy, so the presence of 5 or more medication, cognitive impairment, nutritional impairment, comorbidities, physical impairment, and social support. And this is usually done in the clinic, but if we think of technology, we can start to find how a technological device and tool can be used to help the patient, the physician, or any healthcare professional, and the researchers, and also the institution to find all the best way to treat a patient. So, for instance, for polypharmacy, technology used can be done by, can be aided by putting medication reminders or find the best dose for a given medication. For cognitive impairment, we can develop training, we can monitor medication adherence, we can place reminders. For the nutritional aspect, there is basically monitoring of calories, uptake, weight, BMI, and other metabolic related aspects. For comorbidity, it's good to track, for instance, hypertension, obesity, and other conditions. For physical impairment, technology can be used to put some alerts to do, let's say, physical activity, or to send alert if the patient has fall. And technology can be used to increase social relation of a patient by providing, for instance, social platforms. And the fact that during aging, in aging, is crucial to have a multidimensional evaluation is critical, because it's important to change the perspective. So the most used approach to a condition is the disease-oriented model. In this model, the focus is on diagnosis, prevention, and treatment of a given disease. And here, the pathology of a given disease is believed to cause the limitation of the patient. And so everything is planned within this view. However, in the tailored model, the focus is not the condition itself, but it's the patient and the environment that surrounds the patient. And so the most important aspect here is that the patient has priority over the disease. And according to the Italian Ministry of Health, the goals are not only limited to healing, but at improving the clinical picture and the functional status of a patient. And it is crucial for elderly people with chronic diseases to have an integrated and personalized approach. And it is important so that the disease is treated or cured, but also the psychosocial variables and outputs are evaluated and, if needed, treated. So it is important in this new perspective that all the condition, the situation, the story of the patient is considered by different healthcare professionals, physicians, nurses, psychologists, medical specialists, of course, speech therapists, and so on. So there is a switch in the paradigm of care model in medicine, and it is important that and technology can be used to help this change. Let's say that there are some definitions to be defined, which are the person-centered versus the personalized medicine. So personalized medicine is basically the fact that some biological and genetic and phenotypic aspects of medicine are specific to the patient, and one can set, for instance, treatment according to this characteristic. Whereas the person-centered is the paradigm where the person is not only a patient, but is an active actor during the process of cure and treatment. So it should be observed the complex interaction of the patient with his environment, his needs, his characteristics, and also assess the expectations and needs of a patient. And so this has, of course, an integrated care has a huge impact from the single professional to the policymaker and institutions. And technology could be a good way to help also exchanging information and integrating all these figures and entities in the process of care of an elderly person. So there are different ways that we can take care of a older person. There is the individual way, which is the case management model, where there is a figure that is the case manager that basically study the needs and characteristics of a patient and facilitate communication and monitoring and integration of visits of a given patient. And then there is the chronic care model, which is a person-centered model for patients with chronic diseases, which is based on some aspects, which are the community, the health system, the self-management support, decision support, and delivery system, and clinical information systems that are integrated. But I just want you to provide an example of a multidisciplinary approach of the unit where I work in AUXOLOGICO. So as you see here, there are a lot of figures that take care of a patient. And for instance, in this case, there is the general practitioner, there are doctor specialists, such as physiatrists, cardiologists, there are nurses, nutritionists, social assistants, psychologists, and neuropsychologists. And there are also rehabilitation technicians, so that help the patient to rehabilitate and acquire or maintain their daily activities and functions. There is the physiotherapist, of course, and the speech therapist. And during a KEEP meeting, each patient situation is analyzed. But imagine that with technology, all these figures can have continuous and updated, let's say, information about a patient that they are following up. So there is an integrated situation of, let's say, physical measures, psychological measure, cardiovascular health, and everything is done maybe remotely, so the patient does not have to go every time or for every visit to check up in the hospital. So And also all the figures can talk to each other. So about the case of a patient, a given patient, they can just look at the technology, the application, and try to set the treatment or find out a solution for a given problem. So this is just an example of a patient that we usually see at the AUXOLOGICO, at the unit where I work. So this is the case of a guy that is 75 years old, with 4 years of schooling and married, with a son. He worked as a contractor, building contractor, but now he's retired. There is no history of smoke, alcohol, but he's overweight. And he was recovered for a surgical intervention. And as you see, the clinical history is quite dense because the patient has his surgical intervention to the right knee for a right knee prosthesis. The patient has probable Alzheimer's disease in the early stages. And also he has a complex cardiovascular situation. So he has atrial hypertension, dyslipidemia, and a potential previous stroke. And consequently, the patient is sent to different specialists. So is sent to do cardiological assessment and treatment. He is sent to the orthopedic unit for the prosthesis and for rehabilitation of the prosthesis. He's sent to the neurological assessment. And also, he is sent to the neuropsychologist and physiotherapist to improve the cognitive functioning and physical functioning. And again, the drugs that are given to the patient are more than 5. So this is a typical situation of polypharmacy. And after the evaluation we did, we provided the patient with a set of physical physiotherapy and cognitive training to help him with the knee and with the Alzheimer's disease. So I will go through the psychological and aspects of aging. So aging is characterized by different changes in the system, so biological system. There is also a change in self and cognition and emotion and relationships. Nevertheless, even if there are such changes, there are some aspects that are positive during ages, such as there is more time for personal hobbies. There is more time to engage in strengthening or building affective relationships and in engaging in activities such as physical activities, cultural, leisure activities, or social. So it is good to know the one side of aging, which are the changes that someone can encounter during aging, but also the positive aspects of aging. And I will skip this just to go to this part, to focus on the cognition of aging. So it's perfectly normal that during the lifespan, we change and decline a bit on some cognitive functions. For instance, spatial orientation, memory, psychomotor speed can decline during aging. However, there are some functions that remain stable or even improve. Let's think of semantic knowledge, the knowledge about the world, verbal ability and numerical ability. They tend to remain stable over time and even increase. So the situation change during pathological cognitive aging. And this is the situation where there is a progressive dysfunction, a slow and progressive dysfunction of brain functions. There is a change in memory, learning, language, and attention and executive functions that has a critical impact on daily life and quality of life of patients and caregivers. In dementia, there is a spectrum that ranges from the preclinical part, so where there is normal cognition, normal autonomy, but brain starts to accumulate neuropathological aspects and mechanisms. In the prodromal stage, there is mild cognitive impairment, basically, and then after that, the patient may develop dementia and moderate to the advanced stages of dementia. It is important here in this graph that you see that the prodromal and preclinical stages, in this case, a distance for Alzheimer's disease, but it's the same for other neurodegenerative diseases, that the arrows can go back in preclinical or can stay preclinical. So prevention, again, is crucial if there is a suspect of dementia in a patient. And as I said before, these are the risk factors that are modifiable, that account for 40% of the reduction in dementia. As you see here, there is a 60% of risk factors that is unknown. Okay, so, and if we consider later life, in this very recent report by Lancet, which is a very important medical journal, they showed that smoking, depression, social isolation, physical inactivity, air pollution, and diabetes are crucial risk factors and potentially modifiable factors that can prevent dementia onset. And if we go to midlife, we see hearing loss, traumatic brain injury, hypertension, alcohol consumption, and obesity. And one of the most important is education. So the highest education, the highest engaged mental activity during life, then there is a reduced chance to develop dementia. And we have a different type of dementia, Alzheimer's disease, of course, the most known and common type of dementia. There is also frontotemporal dementia, which is divided in different clinical presentation. There is dementia with Lewy bodies, Parkinson's disease dementia, and or atypical Parkinsonism dementia, and vascular dementia. Then there are secondary dementia, which are due to not to neurodegenerative diseases, but other medical conditions, such as a deficiency state in B12 vitamin may lead to memory dysfunctions. A traumatic brain injury, for instance, may lead to dementia. There is also pseudodementia, which is the cognitive decline associated with dementia in aging, which mimic Alzheimer's disease. But if you treat this condition, you see the memory dysfunction go back to normality. So, as I said, Alzheimer's disease is the most common type of dementia. Then there is vascular dementia, then frontotemporal, and the other dementia. I will focus, given the fact that I have only 20 minutes roughly, I will go very fast here because I want you to show the technological application in aging. So Alzheimer's disease is typically presents with an amnestic form in the early phases, and is a progressive neurologic disorder that leads the patient to decline and have difficulty in cognition, autonomy. So in the early stages, the patient may have memory lapses, difficulty in word finding, and depression, apathy. Then may arise a language problem, so difficulty in speaking. The patient may be aggressive or impulsive, may be obsessive. He tends to wander and getting lost. And then in the later symptoms stage, there is the need of hospitalization, which could be also done in the middle stage phases. And however, having underlying Alzheimer's disease pathology does not always start with memory problem. Research in neurology showed that there are different variants of Alzheimer's disease. It is possible to find the so-called posterior variant, which start basically with visuospatial deficits in patients. So difficulty in identification of objects, words, faces, or may present with coordination and perceiving of the environment. Then there is the logopenic variant, which is starts with difficulty in finding words, basically, and a frontal variant, which starts with dysfunction in behavior and executive functions. Executive functions are basically the function that sustain planning and complex mental activities. Then there is the frontotemporal dementia, which is divided in three main clinical presentations: the behavioral variant, the non-fluent variant, which is a progressive disorder of speech and grammar and word production, and semantic, which is related to knowledge and naming. So even if under a disease has the same name, you see here that there are different clinical presentation, and each of these presentation may have different needs and characteristics. So for instance, the behavioral frontotemporal variant has a huge impact on social symptoms. So patient may be disinhibited, they lose empathy, they are also aggressive in many cases. They have issue of eating and regulating eating, whereas the other forms have more problems in language. The semantic in retrieving and knowing the meaning of words. So there is a loss of semantic knowledge, whereas the non-fluent variant, they have a problem in production of speech. And emotional symptoms may also be present, especially in the behavioral variant, but also in the other semantic variant. Then there is dementia with Lewy body, which is characterized by fluctuation in cognition, visual hallucination, and Parkinsonism. These two features present at the same time, whereas as you will see in Parkinson disease dementia, the onset of dementia is basically 1 year or later during the disease. So there is even if the underlying pathology is the same, so Lewy body, there are different presentation of the disease. Then there is vascular dementia. So I previously mentioned that after a stroke, there could be an onset of dementia if there is a progressive decline after 6 months from the event. However, there are also other cerebrovascular reasons that could lead to what is called vascular dementia. And according to the different bits of the brain that are affected, so there are specific cognitive impairments. So, for instance, if minor strokes or lacunas affect the frontal parts of the brain, there are changes in personality, there are changes in the ability to plan and organize activity, whereas if vascular pathology affect the parietal lobe, there is a loss of speech or even visospatial functioning, and so on. So this is a very heterogeneous type of dementia that depends on which part of the brain is affected by the underlying cerebrovascular pathology. And then there is Parkinson's disease. Parkinson's disease is a neurodegenerative disorder that is purely motor, but can develop dementia, can lead to dementia. So, as I said, compared to Lewy body dementia, here dementia may develop 1 year or even later, and it's characterized by early symptoms of motor dysfunction. So, resting state tremor, rigidity, bradykinesia, which is slowness of movements, and postural instability. And I would like to show you an interesting video from Lancet that shows how patients with Parkinson's disease may have different gait characteristics depending on the stage of the disease. I like the video because makes you notice that even if someone has a disease, the characteristics of that disease and potential solution or aids that we can provide with technology may vary according to the stage of the disease. I try to share the YouTube here, the YouTube video. Okay, so this is a early Parkinson's disease gait, and you can see there is a reduced swing of the arm. So again, here there is low gait associated with reduced swing of one side of the patient, and mild to moderate Parkinson. So in addition to the reduced swing and slow gait, now there is reduced postural imbalance. Here, the change of posture, so the patient leans forward, and then in the advanced stages, there is a cumulative effect of each motor aspect. So as you see here, there is a difficulty in turning, which is a classic features of Parkinson's disease. So here, the freezing of gait is one of the characteristics of Parkinsonism. So the patient has, as you see, it's very difficult for them to to unlock the freezing of gait. Again, here, freezing of gait. The patient has difficulty in initiating the walk. So this video was interesting because it gives you an overview of how specific brain disorders can change over the course of the disease. And given the fact that we are a bit late, I would like just to show you the role of ICT in managing aging patients. So information and communication technologies and technological devices are crucial for three main aspects, which is the assessment and supporting diagnosis, monitoring and management of a given condition, and also rehabilitation and treatment. So the ICT and most of the technological devices can help in supporting and empowering patients. So it's possible with ICT to provide online psychological support, provide patients with information about a given condition. It helps the providers, so the hospital, the institution, but also the healthcare professionals to exchange information about a patient between specialists, and also help the communication and exchange of data and information between the patient and the provider. So with telemedicine, telerehabilitation, teleconsulting, it's possible to increase the quality of life and the treatment that we are able to give to a patient. And this is done also by taking care of the acceptance of the device, whether it's an ICT technology, whether it's a virtual reality, or also a robot, a social robot, or a smart home. It's important that according to the classical acceptance model, the patient perceive the usefulness and the ease of use of a technology. This impacts the attitude towards the technology or the device. And so if I have positive feelings and thoughts towards a device, is more likely that I will have a positive intention to accept it and then use it. And within the context of aging, it's important to consider 4 external variables that play a role in these aspects of the technology acceptance model, which is social influence. So if my cultural entourage, my background do not support the use of technology, which is often happening in the aging population, it is less likely that I will perceive it as positive and as useful. The facilitating condition, if I do not have money to buy a computer, to buy a technology, then I will not use it. Or if I do not have, let's say, grandchildren that help me with the smartphone, then this could hamper technology use. Then some of people that are older, they feel anxiety when interacting with the technology. And then there is satisfaction, and this is maybe is more related to gaming and more fun aspects of a technology. So it is important for you to remind that seniors and elderly have a specific needs when interacting with a technology. And at Istituto AUXOLOGICO, we did a usability suggestions that, for instance, designers and engineers and also psychologists may adopt when developing virtual reality solutions to for assessment or rehabilitation of aging, cognitive aging, which are basically identifying barriers and facilitators. This can be done by adopting the technology acceptance model adjusted for seniors. This can be done with clinicians and diagnoses to find what are the aspects that can be used to facilitate or that hampers the use of a technology. Then there is the development of the task, the virtual reality task. This can be done by applying senior user-centered design, by using specific guidelines for feedbacks, for the interaction with the technology. And then a crucial aspect of usability study is adopting, at least in aging, a mixed method. So you may know for instance, the system usability scale, which is the most common scale that we use when we assess the usability of a technology. However, if you try to administer this tool, this questionnaire to a patient with cognitive decline, it will be hard for him to judge the technology because there is a digital divide problem, and then there is a problem with actual administration of the questionnaire. So it's always good to add the qualitative methods, such as the thinking aloud procedure. Basically, during the interaction, the patient reports some good and bad feelings and thoughts that he has during the interaction with the virtual reality, with the smartphone or whatever technology you want to assess. And there are also virtual reality questionnaire of sense of presence and cyber sickness that are good to administer. However, if during this usability study, the technology is rated as usual and there are minor critical issue to adjust, then maybe you may start to the clinical testing. However, whereas if this is not the case, it's good to adjust the technology. And here, I just want you to show a lady in a trial that we are doing with the cave, which is a virtual room. And she's doing spatial memory and orientation rehabilitation. She is seated and has to collect objects in this virtual city square. She's using a foot motion pad. You see the red device, and she encode and memorize all the location. And after we ask the patient to find the location where he was, the object was placed. So there is a demo of the device. So it is possible to add, for instance, aids for navigation. I will show you in a while. We provide them with the aids. So here there are orange balloons. He has to look around and find all the orange balloons so that he's aware of the environment. He pay attention where he's actually, and then he start collecting objects and memorizing the location. This is just a demo, so it's just one object. And there is this line that helps the patient to find the direction of the object. And there is also the map with cardinal points. And we are studying what is the best aids for rehabilitation purposes. And then we ask the patient to go back to the location only with the wall of the arena, or just with the obelisk, the monument of the square. It is because they assess different aspects of orientation, but just to show you some application of that. And so I'm almost done. So the take-home message is promote active aging by identifying the characteristic and needs of the patient that you want to help with your technological solution, whether it's a smart home or a virtual reality or a device, an iPhone or a robot. So it's always good to know where is the problem and what are the needs of the patient. So thank you very much. If you want to exchange some opinion and have question, maybe you can reach me at my email, and I will be happy to answer all the answer that you have.
Thanks very much, Cosimo. Really interesting walk through the obviously very complex aspect of defining the characteristic of the elderly people. Anyway, if there is some specific question, you can use the chat. Otherwise, I suggest, even if it's not in the program, but it's quite obvious, a 10 minutes stop just to take a coffee and have a moment of rest. And then we will back again with the next lesson that is about the elderly involvement in the process of designing a solution for ambient assisted living. So now we are at 35 minutes past 4, so I think that we can restart at 4:45. Thanks again to Cosimo, and
Lorena, thank you everyone.
See you later. Please be in time to avoid to lose too much time for the end of this section. Okay, see you in 10 minutes. Alessandro, ci sei?
Sì.
Okay, perfect. I think that we can start with the second lesson of this afternoon. The teacher will be Alessandro Pollini, that is a researcher in the area of universal design and methodology for user interaction design. His experience both in academic with as a teacher in various universities, as in the practical application, being a member of a small enterprise specialized in interaction design. So I leave the floor to Alessandro for this lesson on co-design.
Okay, thank you, Lorena. Thank you very much for this introduction, and also thank everybody and the manager of the school for the invitation. I'm very glad to be here, and also try to give a contribution with relation to very specific arguments. And here we will talk about co-design for active living, exploring research and design materials with elderly people. And as Lorena was saying, I'm an interaction designer and will deal with design issues and practical issues with the relation with elderly people or cognitive impaired people. I have an experience throughout my career with kids, school inclusion, elderly people, and I will try here to focus on this last experience, really trying to address an historical perspective on participation and design, just to provide you with a root, with the historical root of the participatory design approach, which I believe is very important to understand the spirit of participatory design and co-design. And then we will enter into active living, the active living concept, which is our target concept for the design activity. And then we will see some materials and methods, how they have been used in practice in the Resilient project, which is an ambient-assisted living project where we are partnering with IRCCS also, which is the coordinator. And then we will conclude, I hope, to make this conclusion together with you in a more dialogic way. So I think that the added value of these lessons are also to have room for exchange and have room for questions and intervention from the participants. Okay, so let's take this open approach to the lesson, and please ask and intervene whenever you feel the need to do that. Okay, so let's start this contribution from my side with this overview around participation and design. The design process involves as participants all those who can be directly affected by the system, its stakeholders. The designer is someone that through encouragement and facilitation enables the participants and stakeholders to deal more effectively with their organizational messes. And I want to start with this definition from the 90s from Pollini, which is an important scholar of the Scandinavian school, the participatory design Scandinavian school, where already in the 90s there was a theoretical formulation of participation as a way to encourage and facilitate all organizational members to effectively deal with their procedure, practices, and artifacts. And we now enter into an exemplar project, maybe one of the first one guiding the participatory approach, which has been developed in the at the beginning of 80s, from 1981 to 1986. The name was Utopia, and Utopia was a project dealing with work, dealing with work quality, and dealing with all the artifacts that, especially in a specific field, which was publishing, were considered to transform work. So how training, technology, and the different interactive products were changing to change work as well. And of course, Utopia is an exemplar project since contributed to the development of methods for engaging users and for letting users raising their voices. So here we don't have specifically elderly users, we have workers, but Utopia was particularly interested since here the group of the researcher were at the beginning of the digital era, but really before digital technologies and services, and they explored at the beginning of 80s many materials and artifacts from representation of what a computer could show until paper prototype. Computers were starting to widespread, and the group of researchers started to understand with the real end users the opportunity provided by interactive system and computers in general. And publishing was affected those days by all the issues now seen also in industry at our times. Since in the publishing sectors, the workers were quite afraid, quite worried about being replaced by computers in general. And Utopia has this main aspect of involving them in shaping the tools and the artifacts. And that's why it's very important for us now to start. And
Center for Working Life is a unique government-sponsored research
would like to show this little video, which is really 3 minutes. I just want to ask you for feedback if the audio is might be listened. So please give me a feedback about it.
Center for Working Life is a unique government-sponsored research institution which assists unions and management in implementing co-determination. Responding to the concerns of the graphic workers, the Center for Working Life initiated a research project called Utopia, drawing participants from universities and labor unions from throughout the Nordic region.
The catchwords were quality of work and product, and by that we emphasize that the quality of the products was an interest of the producers and an interest of the trade unions, and also that just as important goal was the quality of work, the work organization, the skills of the worker, and that there was a connection between the two. So the technology that should be produced should be skill-enhancing tools rather than de-skilling automation.
This unusual goal of creating a computer system that functioned as a tool for extending existing skills forced the Utopia project to invent new research methods. They didn't start by looking for ways to computerize the page layout process. Instead, the research team began by asking graphic workers what new computer tools would help them manipulate graphic elements more easily, give them new creative possibilities, and allow them to produce a higher quality final product.
As computer scientists, I think we carry a heavy load of, say, different techniques that we've learned. Computer programs can be described as, say, formal descriptions. We think that we can walk out and we can study what other people do, their work, and then we can make some kind of formal descriptions of their work. And we found in the Utopia project that that kind of techniques doesn't work at all. There need to be a more direct dialogue with the users who are to take part in the design process.
The computer scientists and graphic workers of Utopia created a mock-up or simulation of an ideal computer-based newspaper graphics system, projecting slides of actual text galleys and photographs to test different methods of manipulating images to create the best possible newspaper page.
Here is composition work or page makeup work on the screen. You see the work material here, and down here you have the screen menu, and from the screen menu you choose the proper operations and the proper tools.
In 1982, the opportunity arose to translate Utopia's ideal specifications into a practical computer system by cooperating with a Swedish company that was planning to build a new computer-based newspaper text and image processing system. Known by the name TIPS, this system is now being tested by graphic workers at Aftonbladet.
Okay, this short video from a historic media library in the Design Archive comes from a different domain that is clear. It's not about active living, it's not about elderly. Comes from a different era. It's not today technology, it's very old-fashioned with this situation with old computers. But at the same time, in this video, there are 4 aspects that are really relevant for us, that are mentioned by all the interviewed researchers. First one is about concerns. This project was about listening concerns from people. It's about listening the inner experience, the inner motivation, and wishes from people. And when they talk about concern, they talk about co-determination, which is very relevant for us. If we want to solve any concerns from people, we should co-determine this, the solution to this, the improvement to this. Second aspect is the joint, the process to join the different interests. They said in this project, interest of technologists, interest of users, interest of producers were merged in a cooperative approach. And this is very important also for us in this situation of the school, since we are several people from different domains and disciplines, and each of us has different interests in producing novel tools and novel technologies. Third aspect is about thinking to tools that are able to extend cognitive function, that are able to improve the experience of people. And also one of the researchers talked about asking people how those computers would help them. Asking the users how they think technology would help them. And this is a very important aspect for us. Fourth one is about methods. And at the same time, they said that we are quite used as engineers to think about the formal description of systems. But since we want to impact on reality, since we want to provoke an impact, we need a more direct dialogue. They use these specific and precise words, a more direct dialogue with end user. And those aspects, from concern to the cooperation, to the cognitive extension, and to the direct dialogue, are the starting point for us for this lesson. And I want to show just some examples of how they worked at the beginning of 80s, which kind of cardboard and materials they used to think about other different interfaces or ways of interact. If future users also actively participate in the design, the mock-ups may be truly useful and a proper move toward a changed reality. And here we put our attention on mock-ups, so the very rude prototype, as in the cardboard before, that allows us to put our hands on future activities, on possible future alternative to our activity. And this is very different from thinking about a system or putting the eyes on a system description, no? As the researchers before was saying, formal description of technology is not enough. It's useful for technologists, designers, developers, computer scientists, or engineers at several levels. It's not enough. It's not enough to let people experiment with or executing some actions, some concrete actions. Those several issues are very helpful for us to start our discussion and will be taken again into consideration in the rest of this lesson. Let's consider our main scope in this context of the lesson, but also in the variety of projects that will be taken into account into this school. And I might talk about resilient. As I said before, this is an ongoing project funded by the Ambient Assisted Living program, and the Resilient is designed to integrate coaching and self-monitoring. So it's taught to emphasize both the sensing and monitoring scope of ambient assisted living, as well as the coaching and the empowerment of people. And the target user of Resilient is the persons with mild cognitive impairment, with cognitive impairment in general, and it's with relation to them that we developed the research, the design, and in the next weeks really the trials. And in this project we started thinking about multi-dimensional approach to active living. So where do we want to go? We want to support elderly people in those several areas: healthy nutrition, their physical exercise, cognitive and mental activities, social contacts and social relationship, as well as active participation to society. And all those different domains are pretty interesting as a starting point for us, since if I thought about those domains, I might think as a designer that we are in front of a very high-level scope in our project. No? It's not that we are thinking about specific purposes or very, very general, but we are thinking about providing active living as within a resourceful aging framework. No? There has been an important research and design activities from guided by Technical University of Delft, Professor Giaccardi, about resourceful aging, how we can empower older people to age resourcefully. And in this framework, also Resilient wants to reach active living basing on those three different concepts: the empowerment, the perceived self-efficacy, and the autonomy. Since empowerment is a very important objective for us, for our own design activity, and empowerment is the way of rethinking about personal ability of acting into the real world, and how this ability might be maintained or reinforced. And self-efficacy is a very important concept, psychological concept, very well applied to several domains. And the perceived self-efficacy is the belief that I have the confidence to act autonomously in reaching a goal. I'm efficient and efficacious in reaching a goal. And of course, autonomy. In our initial research in the project, there was an important statement or requirement collected by end users that wanted to maintain their independence and not being or becoming a burden to the others. And this was one of the main worry and concern from our users. But let's see what does active living means for us, meant for us, through one of the concrete materials that has been developed into Resilient. And I'm going to show some examples of personas and scenarios. Here, just a few words about personas and scenarios. Probably you already know what does it mean, what we mean with personas and scenarios. It's personas are archetypes of users that really integrate a variety of features, a variety of attributes of end users, and are fictitious characters that are built to summarize the user research. And scenarios are the user stories, are the narrative that are used in the design to describe what those characters or users are doing. And in order to make it concrete, I want to show you some example from this presentation of Resilient personas and scenarios. Those are three different stories and characters. First one that we will see is Elizabeth, the autonomous patient, where we try to summarize several aspects with relation to memory, mobility, and social relation. Then in the others, we try to develop other concepts such as self-esteem or support, as well as in the last one, nutrition, autonomy, and physical activity. All those aspects that we are going to see are taken from the user research and the awareness session carried out in the Resilient project in all the different pilot studies we have, meaning Italy, the Netherlands, Switzerland, and Canada, where all the different aspects of the end users have been taken into account. And let's see about Elizabeth. First of all, we might see the description of these personas, the user profile, and this is a fictional character representing our users. Okay, as material, this might be very interesting for you also to think about how the information from the research might be summarized and integrated. Elizabeth is 74 years old and lives alone since her husband passed away a few years ago. Nevertheless, Beth is a determined and dynamic woman. She is constantly on the move. Beth handles all her daily activities such as grocery, shopping, and housework. She is also very active in the social field. She likes to do things for others, like getting groceries for her neighbors. When she gets out, she prefers to walk, but in case of necessity, she uses bus, which is another opportunity to socialize. She has not relevant age-related physical problem, but she recently noticed that her memory is getting worse. Yesterday, she forgot the coffee maker on the fire, but likely no accident occurred. She loves meeting up with her friends, especially to play bridge. Once a month, she goes to the theater. Elizabeth is quite capable with technology. She uses a tablet to search for online recipes and to consult the theater's program. She also uses a smartphone to communicate with her family. What I enjoy the most is being with others. It's just wonderful. Okay, this is a very short description about Elizabeth. Elizabeth is representing one specific target, part of the target we are considering in our design. Those users that are getting aware that something is changing, that their memory, that her memory, for example, is getting worse, and she's noticing the first evidences that something is changing in her approach to autonomy and to managing things. And why this persona is very interesting for us, since we might give Elizabeth a life story. Of course, we might develop an disease scenario, an activity scenario. So what does it mean? Activity scenarios are used in the scenario-based design method to storytell about the current activity, what how the activity is carried out today. And here there is a short story where we have Beth that went out for her usually monthly appointment with her friends. While she was walking to the theater, she realized that she followed the path towards the church and not the one to go to the theater. Adele and Grace called her since started to get worried. When she answered, she explained the reason why she was late, telling them not to worry. Beth worries these kind of episodes are getting to increase and that her habits will change. She likes a lot to be very independent and wants to continue to go out, to spend time with friends and take part in the family life. Beth's most serious fear is to lose her capability to care about herself and not being able to continue her hobbies and communicate with other people anymore. She doesn't think she could bear to be left alone. Starting point of our analysis is about our users, which is realizing that something is changing. She starts to forget things, forget appointments, or forget the routes to get to the theater, for example. And this starting point is used in the design to do what, basically? To understand how this scenario and this profile, the pain points, the fears, and the goals of this character might be, so to say, transformed, changed with the support of a technology, with the support of a system. And that's why from the as-is scenario we pass to the future envisioning scenario. And this is another tool, another material that we used, not to describe the current situation of our users, but to describe the future situation and to build, hopefully together with them, also the description of the experience, the description of their future experience. And let's read it together. Beth doesn't want to give up. She wants to maintain her independence. So she starts using the resilient system. At this time, the resilient system doesn't exist. We still didn't know what the resilient system was about, but still try to describe the experience, how we could shape the future experience. And Beth has filled in her full profile into the system, including her interests, contacts, and recurring meetings. Beth heard that tomorrow evening there will be a performance and sets the appointment on the calendar. The system checks the events organized in town and compares the collected data with those recorded by Elizabeth. The system detects a gap among data. A similar event will take place in 2 days. So it offers further information on the theater program and asks her, are you sure your event is correct? Do you want to check? So here, of course, one of the most important service that was thought about was the coaching. So are you sure? I'm asking for confirmation. I'm asking you to check the plan you are building. And the resilient T also suggests to book the ticket and to invite her friends. So she calls Adele and Grace, and then she buys tickets for everyone. On the day of the performance, the system asks questions related to mobility in order to stimulate Beth to plan the activity. How will you reach the theater? Will you be alone or someone is with you? And the system here is proactively suggest to plan, to execute some function to the users. And also in the last part, another feature, the diary. When she gets home, the system asks how the soirée went, and it proposes to Elizabeth to create a memento, a memory of the evening by adding photos, videos, and personal notes in order to populate her own digital album of memories. Here we saw 3 different artifacts. One is the personas, the description of the intrinsic motivation and the pain point and the wishes of the person, the current situation of the person, but also, and most importantly, the future situation of Elizabeth. And we entered into this description since Elizabeth will accompany us also in the next part of the lesson. But of course, I'm available if you are interested to describe also the other persons, for example, James and Margaret, which are a couple living together, rather than Giorgio, which is another of our fictional users. But it's important for us to take Elizabeth as a reference. Okay, so already I don't receive any notification, but please feel free to intervene if you have questions or there are aspects which are not clear. Okay, so feel free, since it's very important to me. Okay, I go ahead while entering into another part of this lesson, more related to design materials and methods and how they might be used in practice. So we already saw in this example from Elizabeth scenarios and personas, which are pretty well-known methods, at least in the user research and design area. But let's see other materials that could be used. First of all, why we start from materials and methods. since we start from this assumption from David Kirsch, that is an important cognitive scientist. Cognition takes place where it is most advantageous to perform them. By using artifacts or external representation that allow to exploit physical action to formulate and connect thoughts. Kirsch is studying since 30 years distributed cognition and situated cognition, and he is teaching from several decades about how cognition is not entirely taking place into our head, into our mind, but how physical action in the real world is fundamental, is of fundamental importance, and how the artifacts might stimulate this improvement. Combination in our design methodology, there is a combination of artifacts, contextual inquiry and research, and the consideration of different activities. I am using artifacts in a very general approach, in a very general meaning. For us, artifacts are physical design materials and resources that are used to inform the interdisciplinary collaborative design work, and are represented by sketches, so drawings and made drawings, stories such as those ones seen before, prototypes, of course, illustration and mockups. Here we are introducing an important aspect already seen in the Utopia project, which is the interdisciplinarity. And artifacts facilitate interdisciplinary collaboration, since it fosters they fosters collective imagination and give concrete form or anchors to flighty and highly complex idea, and they help communicate the outcomes of design effort. So by means of stories, by means of sketches, prototypes, we are able to give concrete form to our ideas and to our solutions also. And those are very important as a strategy to set up dialogues with other professionals and scholars coming from different disciplines. And this was also what has been done in Resilient T, where designers and clinicians, as well as engineers, try to develop together some novel ideas and concepts to manage cognitive impairment and empowerment and coaching. And in our design approach, there has been a format which I also want to introduce now, which is the co-design workshop. Co-design workshop is the format where we through which we gave concrete and practical application to methodology. And what's the main scope of a co-design workshop? For sure, to reach diverse participation and perspective taken and inclusion. The workshops are not to involve same roles, same people with same backgrounds, rather, they allows us to select participants with diverse background in order to work with a representativeness criteria in mind. So the different persons selected for the workshop are selected on the basis of how much they are representative for the final target users. With the same kind of principles like the personas. Okay, so we have we are building personas and fictional characters to be representative, and we are selecting people in our co-design in order to assure representativeness. And this is the enabling condition for mutual learning. We can learn one each other if we appreciate the differences, if we appreciate the different perspective taking and premises, but also how novel ideas might be generated. And last part of the scope is to enact iterative action, iterative activity. And in order to reach this high-level scope, we started from those three very practical objectives: end users' involvement and participation, the exploration of active living. So we started asking people what do they thought about active living as an empirical exploration, as a bottom-up definition of what does active living mean for them. And of course, also an important objectives in the co-design workshop was about user experience design and interaction design, how people could interact with our system, how people could, which kind of experience could be developed. Those are different sessions taken with project participants, and of course this activity took place within a broader establishment of a methodology which was more centered on establishment of user panel. We in the Resiliency project we tried to have a stable group of people in order to have engagement, in order to assure engagement throughout the project, from research to design and testing. And as I said, we of course started with representative people and representative experiences as a starting point. We didn't take the extreme situations, the extreme experiences, rather than the average and the most common, the very most common approaches. And this allowed us to build those archetypes and also to build the future uses of scenarios. And we try to foster, of course, data collection from their side, the insight, the hints, but also as it was and as it is in the participatory design, also to envision solutions with them and through scenarios and tools, or for evaluating acceptance, impact, and experience. And let's see how we worked into the co-design workshop more concretely, and how the different materials and methods have been used. In particular, we will use this part of the lesson to enter into storytelling, speculation, and prototypes, and to see them in practice. About storytelling, just to start, we didn't took the approach of only textual storytelling, but also visual storytelling to let people enter into a specific feature of the context of use of the tool. So we represented the story, and now we will see. Then, of course, we introduce an aspect which is, we have talked until now about interfaces and interaction. But of course, there has been a very important aspects more related to services, since in our projects to support empowerment and coaching and advising services and their logics, their models, and the different touch points are very, very important. And also, we want to show and share the specific methods, which is called UX statement, which is used to understand and validate both what is acceptable and realistic as an experience, or unbelievable and far from thought. For example, when we used the Elizabeth scenario, we have in our future scenarios some statement, okay? For example, when we read the scenario, we read that Beth has filled in her full profile into the system, including her interests, contacts, and recurring meetings. Okay, of course, we don't know if Elizabeth, or our fictional Elizabeth, would be able to fill in a user profile. So it's a very common action for us. It's very common that we fill in our profile in digital tools. It's very common for us to enroll or to subscribe to a system and to log with a personal account. But we do not know if our end users are available to do that, if they are concerned to do that, if they are able to do that. And of course, in all our projects, we need to start from research, user research about people, but we do not know how this activity can be transformed. And that's why the UX statement method might be useful, since here we might propose a specific statement, and that is also what we did in reality. I state this assumption. I think I can also enter the description of my interest and preferences in the tool and manage a new appointment on the digital calendar. This is an assumption, this is a statement, and we asked people simply to say that this statement is true or this statement is false, right? We wanted to propose a future activity, Elizabeth, that is entering its own description, and we asked if it's true in their opinion and why, or false and why. this might be considered a very easy way of managing the relation and the understanding and the research, but it's very important since it allows us to detach the action and the inner concern, needs, or attitudes of people. So it allows us to a bit divide the possible feature of our system and the possible actions to what is behind the actions and behind the behavior. And again, in the rest of the scenario of our Elizabeth scenario, we continued before we said that Beth heard that tomorrow evening there will be a performance, if you remember, and the system checks the event organized in the town and detects a gap among the available data. So a similar event will take place in 2 days and offers further information to Elizabeth on the theater program. Okay, this is our scenario, of course, but we need to verify this scenario. We need to validate this scenario, and that's why we proposed a second statement, which was, I believe that a tool for checking my calendar and confirming the scheduled event could be useful. So the statement here was about perceived useful feature. If I make clear part of the lesson, you might appreciate the story and the experience, the relation between the future experience and the system and the enabling system, but also the hypothesis checking we are doing. Behind a design solution, there always been there is always an hypothesis. There is always an assumption about. I design a browser since I assume that the tabs are a very good strategy for my users. But materials and methods, design materials and design methods are useful to validate this assumption. And this is also what we are doing. When we asked people about this statement, if they believe this statement was true or false for them. And we continued like this. Just the last example in our scenario, we were thinking that also on the day of the performance, the system asked some questions to Elizabeth about mobility. How will you reach the theater? Do you want to take pictures during the show, if you remember, to create memories and the diary? And here we have other two assumptions, other two UX statements. First one is, I believe that a reminder tool for planning my appointments and sharing my photo would be valuable and stimulating. Of course, those statements might be also turned into negative form. No, I don't believe instead of I believe. This is about the objective of our work, of our validation. Again, statement 4, I would like to have a tool that encourages me to relate to others and cultivate my friendship. This is also a very important assumption in our design. We needed to develop a digital companion, okay, but did we ask people really, if they would like to have a tool that encourages them to relate to others, for example, or to cultivate their friendship. This is why this UX statement is a very practical method to go behind behaviors. And let's go on. Second method we see it's about speculation and speculative design. Since once I have a story, I can also think about alternative future. I can also imagine possible alternative course of action in user stories. Again, with a very practical method, which is the what if method. What if I introduce a novel system or a novel feature or a novel actor in my story? And also the affinity diagram. And let's see what they are about. The what if methods is used to examine the participants' thoughts towards improvement of experience. We asked them to think about what if they were the main relatives of designated users, or what if they were the shoes of caregivers, or if they were younger, for example, just to change personal features. And affinity diagram instead is a method that allows us to elaborate a variety of data about user experience into broader clusters, into broader research teams, in order to see and visualize the motivation, thematic clusters and areas behind, the affinities behind the data collection. Last one is about specific prototype. We dealt with horizontal and vertical prototypes, which means horizontal that shows and implement one specific feature of my system, or vertical, no, sorry, the opposite. The horizontal one are those ones that implement a variety of different features, but not with a specific detail of them. Instead, when we think about the vertical prototypes, there are limited numbers of features, but developed in details. And another different kind of prototype being used in our research and design is the mock-up used for the Wizard of Oz. Wizard of Oz is another technique quite well established in literature. Wizard of Oz is useful when you have not a functioning prototype, but you need to behave like the wizard, playing the magician. So you stimuli and triggers and notification to the users, as well as feedback. With those different prototypes and mockups, we follow a specific model, the prototyping model of Hood and Hill, which highlights on 3 different aspects of prototypes. You might have role prototype, thinking about the role that they will take into the activity, and the implementation prototype, which which better develop and focus on engineering of the system, of the feature, and look and feel. You might have also look and feel prototypes or mock-ups which implement the aesthetic appearance of the prototype. All those different prototypes have been used. Here you have, for example, an example of the tablet, which have been used, as you might see, connected with another system to show how the future system would work. And here we might also see concretely the different prototypes we used. Those are made with XD and projected with a tablet. Okay, this was only a cover. But let's take the other one about Elizabeth, since we used Elizabeth as our case. Okay, so what they saw into the tablet. We started by using a grid, a specific tablet layout grid in XD, and started to figure out how the system would appear. And again, at this stage, we didn't know how the system would appear, but we tried to figure out some hypotheses, some ways of thinking about this tool. And here, in this part of the mockup, there has been the calendar function, no? As we saw before, there is our Elizabeth, which is fixing in his calendar the theater, the event at the theater with the related promemoria notification. Now, in this interaction, of course, with the users, this was a guided interaction. No? We helped them to understand how those different sequence of actions related to the story, related to the main aspects of the scenario. And here there is the creation of the event, and then we tried also a different strategy, since when you are using a mock-up, you can play, you can imagine a different situation, and we tried to think about this object, our tablet, in the elderly people home, in the context of the elderly people, and not only to think about this interface as a information provider, as a notification system. We try to envision how it could also foster expressive interaction, or as you are confident with several frameworks, you can think also about the Calm technology framework and so on, where the tablet, our system, which includes a tablet, our system might capture the attention of the user while changing certain shape or certain colors, or emphasizing some interaction. And here there is the trigger to the attention to the user, and then the concrete service, the service where the system is saying, okay, a similar event has been detected. It's still l'Elisir d'Amore at the Scala Theater, but it's a different schedule. So do you want to check? If you remember, this was one of the functions of the system. And this is the relation between the story, the narrative, with the prototype. And here we tried them to interact with this scenario and to make it concrete. No? Here it's not the intelligent system that do the check for you, but it's the coaching system that allows you to checking by yourself. And here, after this check from the user, the system is also suggesting that according to the friends community, some friends like Adele and Grazia will take part to the event and suggest to enter into contact with them and to possibly plan a social activity. Okay, this is one of the scenario we developed. As you might understand, it's only an interface mock-up, but has been very useful since allowed us to transform the story into an interactive experience, still not having any proper prototype, no? And that's why also was useful to collect, for example, how complex this feature was, how complicated the interaction with this system might be, and also allowed us to change a bit the story. No, for example, we tried in an iterative prototyping perspective, we tried also to change a bit the story and to introduce further different aspects in our Elizabeth story. So here we have also some other sketches that allowed us to show what does a profile was, since we are all basically digital people, or quite passionate and trained with digital technologies as researchers, as professionals, but we can't given for granted that all our users, especially elderly people, knows about user profiling. We might validate also some specific concept. What's a user profile, which kind of information a user profile will contain, and what's the goal, how and why I could interact with the system, how and why I could give to the system my own information, right? So we need to, as at the beginning of this this contribution from my side, what are the concerns of the users about giving their own profile data. And same was about calendar. So before providing them with the mock-up, we tried to explore also with sketches. Okay, this is a calendar. Are you using a digital calendar? Are you using a sheet calendar? Are you using an agenda, a personal agenda, a paper agenda? And this was very important just to focus on user requirements, stories, and how to make our personas effective. No, please think that Elizabeth is one of the most optimistic representative of our users, right? Since she is very active, she is very into social life, and she is very active in relating with others. But we might also have several other and different profiles or users that haven't seen a digital calendar in their life. So that's why those materials and iterations are very helpful for you and for us to understand better. And also, for example, when we talked about diary, of course, our users, we are quite confident with photo gallery and pictures, gallery of pictures, navigating digital pictures, but probably this is another aspect that needs to be validated with them. How do they conceive a digital repository of pictures? How they could navigate through it? Okay, this is not given for granted. Okay, then we had also some other different materials, but I don't want to enter into those examples. So those are more related to another story, which is about other users, where we explored the shopping list, the buying experience, as well as the orientation in space and the use of map. In this scenario, we also explored an important part in Resiliency, which was about the wearable technologies and physical activity, since we went into cognitive training and cognitive experience and memory loss, but in other scenarios we talked about physical activity and guidance to move into the physical space. And in the last one, we entered into another different domain, which is healthcare self-management, so the management of personal health conditions and the connections with other equipment, or the suggestions for a diet, healthy diet, or dietary habits. And we have been taking several examples, personas and scenarios, UX statements, prototypes and mock-ups, or Wizard of Oz that do not contain any intelligence, but that allows us to verify which kind of intelligence our users are ready to meet, are ready to experiment. So this is basically the conclusion. I wanted still, if we started a bit with delay, I wanted to not steal any more time, and this is basically the conclusion. I really would like to conclude with some interaction. I'm curious about if do you have any experience about those methods, if you already knew some of those methods or have experience with them. It's very important and could be helpful for the other participant as well. So feel free to comment or ask about these methods and this activity we described. I don't know, Lorena, maybe we can have those last 5 minutes or 10 minutes.
Yes, if there are any questions, please, Alessandro will be happy to answer to you.
Yeah, also if
you can raise your hand, you can write or even directly talk.
Yeah, sure. Also, if you want to go into some further details and if you need some resources, no problem to share them.
Probably they are a bit overwhelmed by his abundance of information that I've received today.
Yeah, I understand. I understand.
Okay. Anyway, I have posted in the chat the 3 questionnaires that you have to fill in, the assessment of the 2 teachers and the learning assessment related to the day. So please go to these links and complete the questionnaire within 1 hour. Then, if you have any question even related to this part, please feel free to ask.
It looks like an intensive start of the school.
Yeah.
And okay, I hope to have touched some interesting issues for you. So,
Andrea, I think that if you can leave the section for some minutes so that everyone can go to the questionnaire and to have the link available in the chat. And for the rest, I think we can, if there are no questions, I think we can close for today. And we wait to see you again on Wednesday at 3 o'clock in the afternoon.
Yes, now we can, I mean, how many minutes do they have to complete the...
Yeah, they have, usually when we do the questionnaire offline, we ask them to do within 1 hour.
Okay.
But it's not necessary to 1 hour to complete the questionnaires because are about 8 technical questions and I think 6 plus 6 questionnaires to assess the teacher. So they are. It's not necessary. Probably they take 10 minutes, even less, but we give to them enough time to be there in completing.
At this point, we will leave for some minutes the link that we have
someone said that no cannot see. Is let me see. If you open the chat, there are some messages, and there is a message from me with the 3 links.
Yes, exactly. You have to go to the chat, and on the chat you can find 3 links that Lorena has already provided. And the first one is the teacher assessment about Tuena. The second one about the Pollini, and the last one is the learning assessment. So
I don't know, Andrea, if you can anyway send the links to them. If you have a mailing list, you can send to the mailing list just to be sure that everyone received.
Yeah, I can also provide them by email, of course. There is no big issue.
I'll forward to you the same information in mail, so just you can forward, just to be sure that everyone have received them.
Yeah. Okay.
Okay.
Just a second, because I have to copy this.
Okay. In case there are not any further questions, I just wanted to thank you again, Lorena and Andrea, and also we'll be happy to meet you in a few days. Okay.
Okay.
Bye-bye. Bye-bye, everybody.
Bye.
Bye. Thank you.
Bye.
Thank you, Alessandro. Bye.
Ciao. Bye-bye.
Okay, just a second.
Yeah.
So, and at the same time, I would like also to clarify regarding the certificate of attendance and the credits, the CME credits. So all the people who have attended the course, of course, will be provided of a certificate of attendance, and the people who has requested, or if they want have the CME credits, please, you can you can complete the learning assessment in order to.
And even for the people that need some certification of a test, for example, to be to have this school evaluated, for example, for the PhD credit and so on, if they have to demonstrate that they have a final test, obviously they absolutely need to complete the test.
Yeah, that's true. So at this point, I can provide these links by mail. Okay. To all participants, and you will be in carbon copy with the mail. And so at this point, I can see that we can close, the day one summer school, saying thanks to all the participants who have attended to the today course. And Bruno,
it's possible just to have an idea how the people that we have. For the people that is still, ask to them to switch on the cameras just for a minute, because it's quite an annoying.
At least to see all of us.
Obviously, during the teaching, it's better to take the camera off for obvious reason, but just for a second to see the face of the people that are here.
At least to see each other. No?
Yeah, it's much more nice to talk with some face than to a black screen. Okay.
People is coming still.
Yes.
There is one question in any case, Lorena. Is the certificate of present days and hours?
Probably yes.
The certificate are present the days and hours. They have attended the course.
Yes, I think yes.
This is related to the certificate of attendance. Okay.
Yeah.
Yes. Okay.
Okay. Okay.
It seems that there are many attendees which still have the camera off, but
I hope that no one has leaving the camera, we leave the connection on and is doing something else.
I hope no. Also, why they have to fill out the test, which.
Okay.
Okay.
So go ahead with the test, and we'll see
you on Wednesday.
Yeah, on Wednesday. Exactly.
Bye bye.
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 Thank you. Bye bye.
Bye bye.
Bye guys.
Bye.
Bye.
Buona serata. Ciao. Bye.
Bye bye.
Bye.
Bye.